Hello, and welcome to the routine replacement of a low-profile balloon gastrostomy tube in pediatric patients, a video for clinicians, brought to you by the American Society for Parenteral and Enteral Nutrition and supported by Avanos Medical. The purpose of this video is to educate authorized clinicians about low-profile balloon gastrostomy tube routine replacement so they can perform this task. Individual institutions will determine who is authorized to do so. The audience for this video is any healthcare clinician who is authorized to replace an infant or child's LPBG on a routine basis. This video will not address the routine care and complications of these tubes, just the replacement.
Hello, my name is Dr. Derek Wakeman, a pediatric general surgeon from the University of Rochester in Rochester, New York. Joining me is Beth Patton, pediatric nurse practitioner from the University of Tennessee at Le Bonheur Children's Hospital in Memphis, Tennessee. The learning objectives of this video are to discuss the process of patient assessment prior to routine low-profile balloon gastrostomy replacement to determine if consultation with another specialist or senior staff member is warranted. Relate clinical scenarios that warrant special consideration prior to routine replacement. List best practice methods for placement and verification of the replaced tube. Explain when other methods should be used to verify the newly replaced tube. And summarize how patients can be monitored post-replacement of a low-profile balloon gastrostomy tube. A low-profile balloon gastrostomy, or LPBG tube, is a skin-level device held in place by a water-filled retention balloon. It requires periodic replacement and upsizing in growing children. It allows for intermittent or continuous gastric access for feeding, hydration, medication administration, and/or venting. Indications for low-profile balloon gastrostomy routine replacement in children include initial planned tube replacement scheduled 6 to 12 weeks after tube insertion, weight gain resulting in tube fit being too snug, periodic replacement based on the manufacturer's recommendations, and wear or injury to the device, such as failure of the balloon to retain water. The low-profile balloon gastrostomy tract is the area between the abdomen and stomach, as seen at the arrow. With growth and weight gain, the tract becomes thicker, requiring a longer stem, or shaft, which is measured in centimeters of length for the tube. Accidental misplacement of a low-profile balloon gastrostomy tube can result in the balloon tip in the peritoneum, not the stomach, called the false tract. There are many brands of these enteral devices on the market. The components of the tube are similar. The balloon, stem or shaft, also called tubing or stomal length, balloon water port, and access port. The balloon port is for inserting water to inflate the balloon and should not be confused with the feeding port on top, where an extension set is inserted for feeding. Resizing is based on the stem length, also called tubing or shaft or stomal length. See the navy arrow. Tract maturation refers to the healing of the low-profile balloon gastrostomy path from the abdomen to the stomach by forming scar tissue that seals the area to allow for safe tube replacement. The first change is usually performed 6 to 12 weeks after initial placement in the provider's office or clinic. Individual institutions should have a written policy regarding when tract maturation is deemed adequate to allow for initial replacement. Conditions that warrant consideration to wait longer for initial replacement include conditions associated with delayed wound healing, such as diabetes mellitus, chronic steroid use, ongoing cancer treatment, or other conditions that may delay tract maturation, including presence of a ventriculoperitoneal or VP shunt, presence of a peritoneal dialysis catheter, especially if peristomal leakage is present, or ascites. Patient assessment prior to replacement includes several steps. Evaluate the low-profile balloon gastrostomy for fit. Is the fit too tight or too loose? Are there problems with fit when the child is in sitting position? Assess the stoma site. Is there a stoma site infection or granulation tissue requiring treatment? Consider the timing of tube change. Has the child just received a feeding? If they have, you might want to wait to replace the tube. Tell the parents not to feed just before exchanging the tube. If the tube no longer fits well, it may be best to resize the tract length with a stoma measuring device as shown below.
Recognize the need to resize a low-profile balloon gastrostomy tube is important. Failure to routinely upsize a tube in a growing child can cause a gastric mucosal ulcer from compression of the tract. Growing infants and children need to be evaluated for tube fit periodically to prevent this harmful event.
G-tube resizing. Gather the supplies you will need. After performing hand hygiene and donning clean gloves, dip the end of the stoma measuring device in water-soluble lubricant. Deflate the balloon of the existing tube. Pull out the existing tube out of the stoma. Insert the stoma measuring device through the stoma and into the stomach. Attach a slip tip syringe filled with water to the balloon port of the stoma measuring device and fill the balloon to the recommended fill volume. Gently pull the stoma measuring device away from the patient until you feel resistance against the abdominal wall, and with the patient in a supine position, slide the disc down to the stoma. Note the marking on the top of the disc in centimeters. Now slide the disc up away from the stoma, and with the child, you will have the child sit in an upright position. Slide the disc down to the stoma and note the marking at the top of the disc in centimeters. Record the average of the two measurements. Attach an empty slip tip syringe to the balloon port. Pull back to remove the water and deflate the balloon and remove the stoma measuring device.
Gather the supplies needed for routine replacement. You'll need a replacement kit, which includes a low-profile balloon gastrostomy tube, extension sets, slip tip syringe for balloon deflation and inflation, infit syringe, gauze pad, an insertion stylet. Note that not all kits have stylets. Lubricant. You also need hand sanitizer and purified water. Purified water refers to water that is free of contaminants, chemical and biological, following source water selection, distillation, and filtration, and should be used in a clinical setting. A source of purified water in a clinical setting is sterile water.
Attach an empty slip tip syringe to the balloon port of the existing G-tube. Pull back to remove the water and deflate the balloon. Remove the existing G-tube by gently pulling up the device with slow and steady pressure. Insert the new G-tube into the stoma until it is flat against the skin. Remove the insertion stylet. Attach a slip tip syringe filled with water to the G-tube balloon port. Fill the balloon to the recommended fill volume. Attach an infit extension set to the feeding port, and then attach an empty infit syringe. Pull back to draw out gastric content. This will confirm correct placement of the G-tube within the stomach. If you cannot aspirate stomach content, roll the child side to side or sit them up and gently push on the stomach. Try to get stomach content again. If unsuccessful, wait 15 to 20 minutes and try again. Do not use the G-tube if you cannot aspirate stomach content and notify the provider. Now let's see how this looks like on a child.
Verification of newly placed low-profile balloon gastrostomy tube includes the following steps. Insert the extension set, attach the infant syringe, and aspirate for gastric contents. Additional measures, if unable to obtain an aspirate, include turn the child on their side and wait 10 to 15 minutes before rechecking for an aspirate. Typically turn to the left side, but in some children the right side works better. Consider installation of a small amount of sterile water and recheck for an aspirate. Additional measures for verifying the position of the newly replaced low-profile balloon gastrostomy tube include, prior to removing the in situ low-profile balloon gastrostomy tube, aspirate fluid and compare its appearance to the fluid aspirated from the newly replaced low-profile balloon gastrostomy tube. Prior to replacement, instill a colored beverage into the in situ tube and compare the color of the fluid aspirated from the new tube, or check the gastric acidity of the fluid aspirated from the newly replaced low-profile balloon gastrostomy tube. If it is less than 5.5, the tube is considered to be in the stomach. Situations for when to call in a senior staff member may be a difficult time with routine replacements, such as the tract is too tight and the tube won't go in, the tract needs dilation, such as with Hagar dilators versus Foley catheters, the change just doesn't feel right, excessive bleeding, inordinate pain response, signs of infection, excessive fluid leaking into the abdomen, such as with ascites or peritoneal dialysis fluid. Once these situations are resolved, initiate a contrast study to verify placement. Suggested patient monitoring post-replacement includes rotate the newly replaced low-profile balloon gastrostomy tube and observe for ease of rotation, any discomfort seen with rotation, bleeding or fluid leakage. Monitor the patient during the first use of the newly replaced tube for fussiness or pain, abdominal distension, and any difficulty with formula or fluid administration via the new tube. Documentation comes in two parts: the patient and current tube assessment and the tube replacement process. First, the patient and low-profile balloon gastrostomy tube assessment. Type and size of original tube. How long has the patient had a low-profile balloon gastrostomy tube? Was this the first replacement? Were there any issues with the stoma, redness, leakage, infection? Were there other factors to consider? VP shunt, PD catheter, ascites, steroids, cancer treatment, etc.? Were any consultations requested? The second part of documentation includes the replacement process, noting the type and size of tube, manufacturer lot number, amount of water instilled into balloon, ease or difficulty of process, patient tolerance of procedure, complications if any occurred. Also note confirmation methods used, referrals made if indicated, and patient monitoring prior to discharge. Here are some references for this video.
This educational offering was provided to you by ASPEN and supported by Avanos Medical. ASPEN wishes to thank Children's Mercy Kansas City Enteral Access Team for the patient videos.